Hello, my name is Dr. Shama Patel. I'm an emergency physician and assistant professor of emergency medicine. Today, I'm going to talk to you about global health ethics. So the objectives today are, we're going to define ethics as a whole, define what global health really means, and then what global health ethics is, which is a pretty new topic and not well defined. Ethical guidelines for global health experiences, some case examples from my own experience, and then some resources that are available. So morality and ethics. What is morality? Morality is concerned with the principle of doing right. It is the barometer by which we measure right or wrong. Morality is different for different people and different cultures. Ethics is the scientific study of morality. It makes it more objective. Well, as objective as ethics can be. It is the principles that govern a person or group's behavior. It is the rules of conduct. Ethics is a critical reflection about morality, and various levels of ethics exist. For example, there's microethics. Microethics is focused on the provider-patient relationship. This is what we do on a daily basis. Meso or mesoethics are what institutions are responsible for. So you can think of that as what the local health department is responsible for, or NGOs are responsible for. Macroethics is the city, state, country level, and these are more public health ethics. And then global health ethics can be seen as crossing global boundaries. There's much debate on the definitions and what is global health, which is our topic we're going to talk about next. But first, all of us know the Hippocratic Oath. Most of us took it when we graduated medical school. It's the earliest Western world expression of medical ethics. It was written in 245 AD. This is here on the left, you'll see the Greek version. Today, the oath has taken on a modern form, but certain principles remain from both the original and modern forms, which include medical confidentiality, non-malfeasance, and first do no harm. I'm not going to be able to say that line term. These principles still hold dear today, and we still abide by these in our patient-provider interactions. So the professional ethics that are considered today that I know many of you remember from medical school, we'll go over very quickly. These are beneficence, non-malfeasance, respect for autonomy, and justice. Beneficence is the idea of doing good. Most of us went into medicine for this reason. We wanted to do good and improve our fellow human beings' well-being. This principle was present in the original Hippocratic Oath. As to diseases, make a habit of two things, to help or at least to do no harm. It's written into the Hippocratic Oath. Although it may seem that beneficence is simple and to do good is easy, but that's actually far from simple. So what does it mean to do good? In one culture is, for example, in America, personal autonomy is very important. Therefore, individuals have the right to know their health information. In another culture, it might not be acceptable or socially or culturally acceptable to tell an elderly person they're dying because this might hasten their demise. So are we doing good by practicing the way that we practice in the US in a different country? I would say that we really need to look at culture before we engage in these kind of topics. And so doing good is not as simple as doing good. Non-malfeasance is written into the Hippocratic Oath. I will keep them from harm and injustice. In global health, what do we mean? Well, beneficence and non-malfeasance go hand in hand. My question to us is, can we really keep anyone from harm, or is our goal really to minimize harm? Because even giving an antibiotic for a urinary tract infection can cause harm, can cause anaerobial resistance, can cause diarrhea, can cause other side effects and adverse events. What we all call harm varies. For example, before we are doing more harm than good, are we minimizing harm? So for the example I would give before about the elderly patient, are we doing more harm by telling that elderly patient that they have a terminal cancer diagnosis, or are we doing less harm by not? That's going to depend on the culture, the cultural norms as well. So respect for autonomy, we've kind of touched a little bit on this. Um, it refers to self-determination, the freedom to act independently, and the individual's ability to meaningfully participate in their own healthcare. Its paramount principle is that individuals are free of coercion or undue influence. Autonomy is not absolute. It can be limited by things such as unacceptable medical practice, non-beneficial treatment, violation of deeply held beliefs, limited resources, and no decisional capacity. And potential in global health to violate autonomy as well as overestimate autonomy. So we can violate autonomy in the global setting by assuming that the patient doesn't have the capacity to understand. Language and cultural norms can also hinder what we deem as autonomy. And an important question to ask when working abroad is who has autonomy in that culture? Who is the decision maker? It is not the individual, it could be the group, it could be the family, it could be the tribe. Western approach to autonomy is more individualistic, but other countries it is more important to incorporate familial and communal ideas of autonomy. Many cultures don't abide by the autonomy, the individual autonomy that we here do. So for example, Islam is a neighborhood first type of culture and autonomy. Tribal cultures in many respects put the tribe above all else. So some don't even know what autonomy is when we go to these different countries and we work with these different cultures. So is it our place to change their culture and their relationship to the world? I will talk about this a lot later on, but it's important to take the lead from your local partners and local experts who have the cultural knowledge, and it's really important in just talking about ethics in general, how much of your ethics would you impose onto another culture? And that's a good question to continue to ask yourself. Am I imposing my worldview and changing the worldview of others? And is that the right thing to do? Is that the ethical thing to do? So justice is our last professional ethics that we talk about. It's the principle that deals with fairness, equity, and equality. It is how we determine the allocation of resources. This is especially important in the global health arena, as there are only a finite number of resources and multiple people vying for those resources. Approaches to fair distribution include utilitarianism, which is the greatest good for the greatest number, which is a lot of times the way we respond to MCIs and mass casualty incidents. Libertarian, those who provide greater value for society benefit more than those with lesser value to society. Egalitarian, which protect the most vulnerable. So comparative justice, making a decision based on criteria and outcomes, which is uncomfortable as we work in a system with competing resources and finite number of resources. When discussing distribution allocation, it can come down to comparative justice. So for example, if you're on a transplant list, should it be based on your health status, your age, or should it just be a lottery system? Those are different types of justice, and not one is wrong and one is right. It's all dependent on culture and ethics of that culture. So as you've noticed, a lot of what I talk about is a bit esoteric and philosophical. So I just wanted to give the background of what our professional ethics are and how those are going to apply when we go abroad and go on short-term medical trips. Before we get started on global health ethics, what is global health? We know what it is, but it's hard to define. So there's a good blog post that really goes through the four kind of iterations of global health. So global health 1.0 is tropical medicine. This was in the 1800s, early 1900s, which was primarily concerned with colonizers keeping those people alive. So a lot of times it was keeping the white men alive in the tropics, is a very simplistic way of looking at it. Global Health 2.0 changed to international health, and it really comprised quote unquote clever people in rich countries doing something to help people in poorer countries. And then that changed to what we talk about now, which is global health, which is a lot of times researchers from rich countries leading research programs in poorer countries. I just want to spend a moment and just define the kind of difference between international health and global health. So international health focuses on issues of countries other than one own, especially high-income countries working in low-income countries. Solutions require a binational cooperation, and it's not really multidisciplinary, it's more vertical programming and silos. Then global health 3.0, when we started using the term global health, and this really includes issues that transcend national borders, ensures, and it really needs to have global cooperation, not just bi-directional cooperation. It's health equity for all peoples and focusing on both equity and equality. And it's more interdisciplinary and multidisciplinary. So you're looking both at the direct and indirect effects, as well as the downstream and upstream. And then global health 4.0, where are we going in the future? So what this blog post kind of succinctly said was that research and other activities being led by researchers and providers from low and middle income countries, which would be the way that I personally view the future of global health, is that we are learning more from LMICs and those countries that initially were being colonized, but they're the ones teaching us the lessons. And I think the greatest example that we all know of is COVID. We had all the high fidelity simulations and high fidelity resources, and yet we still couldn't do as much as we thought we could do. And sometimes that low fidelity and resource limited settings can really help us determine when we are resource poor, like we were in COVID, to how to utilize minimal resources. So instead of even being bi-directional, it's that the global south is teaching the global north now, which I foresee hopefully being the future of global health. I do want to make just a conversation and a plug about decolonization. So decolonization is really becoming a big hot topic, and it really has been increasingly used in many spaces with a wide variety of meaning. Really what it means to me is it's a movement that aims to address a legacy of colonialism in global health and the pervasive imbalances of power, representation, and resources. So the reason I'm mentioning decolonization within the global health ethics lecture is that it really does, a lot of the ethical dilemmas stem from a colonial mindset. Whether we know it or not, the high income countries going to low income countries, that's kind of how global health has been designed for many, from really its inception. And so kind of changing that narrative and changing the language may seem small, but it actually has a very large impact. It also represents an undoing of colonial influences and restoring power and control to those that are colonized. But we must recognize, I just want to put this there, that this is, again, high income countries leading this charge of decolonization, which it really should just be led from the ground up. Just reiterating some of this, it's a really good quotation that global health institutions typically based in the global north often lack representation of key communities at the decision-making table and end up perpetuating an American Eurocentric worldview that do not adequately consider most of the world's needs or local community in which they intend to serve. So in a lot of ways, global health is neither global nor diverse. And remember that the global health, these words were all designed by high-income countries or those that were colonizing, not those that were colonized or those from low and middle income countries. So I just want to use examples of some of the language that we used to use for this kind of work: white saviorism, medical voyeurism, or volunteerism, which still exists today, which is the for-profit way of providing medical care to those that are deemed vulnerable or that we need to help. I want to caution against using that terminology because it really disempowers and devalues the agency and the ability of the local population to really manage their own health needs. There's also lack of parity in research and authorship. During this talk, I'm not talking too much about global health ethics in terms of research, as there's been a lot done in that world. And I can direct you towards some papers and some presentations that really succinctly focus on that. For example, education materials all written in English. Another big thing is that we tend to have conference calls and Zoom calls with our colleagues, but we make them that are convenient for us, but it might be 3 a.m. for them. And recreation of inequities that we actually seek to undo is a big issue. So to not perpetuate the power imbalances and the colonial mindset is really important. So just defining global health through the literature, these are the two most used definitions. It's the Copland definition, which defines global health as an area for study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. And the WHO, it states that it The global health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So now defining global health ethics. It's a new shared paradigm for global health ethics, would increase capacity for all decision makers involved in global health research and practice by combining both moral and scientific starting points for research with a more comprehensive relationship model inclusive of solidarity and social justice. So the main theme in global health ethics is rooted in social justice and equity. And so here you can see the definition that was developed that I could find in defining global health ethics. So global health ethics is a field of applied ethics, inquiry and practice, offering critical exploration, including self-reflection, interprofessional, transdisciplinary, and transcultural dialogue, rigorous analysis, and normative guidance, attempting to capture what is relevant to decision-making regarding the distinctive context, challenges, dilemmas, and constraints of global health education, research, service, and North-South partnerships, aiming to reduce global and local health inequities affecting marginalized populations between and within countries. So it really focuses on inequities, which is really the heart and the root of global health ethics. It also draws upon multiple domains of applied ethics, including social ethics, professional ethics, clinical ethics, business ethics, organizational, and decision ethics, public health ethics, as well as classical bioethics. It also offers evolving and expanding rationales, as well as distinctive core values, concepts, principles, codes of conduct, and frameworks for transformational approaches for global health reform. This is a pretty loose and broad definition. I think right now there, a lot of like philosophical people, bioethics people are trying to figure out really what global health ethics means. This is the most comprehensive definition that I found, and I thought that I would share that with you. So global health ethics, the fundamental question really I see is what place, if any, do race, ethnicity, and culture have on moral theory and ethics? And then remember that ethics is a science of morality. I know morality and morals can become a hot topic and be polarizing, but really we're talking about morality in the terms of ethics. So applied morality and objective morality is ethics. That's what we're really talking about. So answering this question, I would hazard to say that culture, race, ethnicity play a major part in moral theory. What we deem as moral is different based on our experience and culture. When working in global health, this is amplified. And so when working in global medicine, you need to embody humility, introspection, solidarity, and social justice, as well as the 4 professional ethics we talked about earlier. The specific global health issues, the colonial morality. I've worked globally for almost 15 years myself, and I sometimes find myself even now saying, in the US, we do this or we have this. I have to check myself constantly and re-examine what I'm doing to make sure that I'm not perpetuating that colonial morality. Our job is to not export our belief system to low and middle income countries, as it doesn't apply. It's not necessarily relevant to their context. It is more important for us to hold our professional ethics in high regard, but adapt them to the country context. We are highly trained, sometimes more so than local staff, but we are not highly trained in their culture and the cultural norms. So I also would caution against practicing outside of your scope of practice. This has happened a lot. It's happened in places like Haiti. It's happening in Ukraine right now. So if you go outside your scope of practice, you're risking 1, your professional ethics, 2, legal ramifications, and 3, changing the dynamics of local patient provider and local healthcare delivery. Power dynamics. Remember that there's always a skewed view of power throughout the world. And then if we're coming from a high income country, we already have embedded power within that. Because maybe because of the race, because of what they deem our education system to be. So whether you know it or not, being from high income country already gives you more power over those that you're trying to support. You have to be cognizant of how the community sees you, as they will in many cases defer decisions to you, which may not be right, or which may not be ethical. I shouldn't say right. When I'm saying right, I do mean ethical. Remember, you may be more trained in terms of EM, but you're not more you're not more trained in terms of their culture and society. And then a really, I think, big point that we forget to mention is that the importance of the difference between the meaning of health and death, depending on what culture you come from. Many times it has, religious undertones of the spirit is causing an ailment, but all of those things are cultural differences of what it means to be healthy and what it means to die. And those we need to recognize and know and take a lead from our local colleagues about how to talk about those sensitive topics, but make sure that we're being culturally appropriate and ethical in terms of not imposing our value system onto a different culture. So what is a global health experience? I kind of think about global health experience in 4 buckets. So global health education, teaching, research, and international clinical service. So really what I'm talking about here is short-term experiences in global health, which are called STEGs, which is a new terminology that's used for kind of encompassing all of this work. And they focus on the experience the medical student, resident, or physician engage in. So global health education includes developing residency education, but also includes EMS training, first aid training, trauma and resuscitation education. Teaching overlaps with education, but you can be tasked to teach various courses. Research, much focuses on new and existing research and how that relationship plays out. How does authorship play out? Is there authorship parity? When in designing experiments and designing randomized controlled trials, is it locally driven? Is it clinical questions that are relevant to that community? And then international clinical service, this can be direct patient care, especially in disaster and humanitarian events. And we've seen examples of responses, both well done and not. The Haiti example from last decade was really poignant and actually led to the development of emergency medical teams from the WHO, because so many people went to Haiti and practiced out of their scope, did procedures that they were not trained to do or were not ethical. There are a lot of ethical dilemmas. There's been a lot written about it, and you can email me at all and I can tell you kind of where to get that information from. So really what we're talking about are short-term experiences in global health. And so there have been some global health training ethical and best practice guidelines developed by the one group is the weight working group. And then also the Annals of Internal Medicine, the American College of Physicians have also put out several different positions on what is ethical in terms of short-term global health experiences. So a lot of times what we think about short-term global health experiences in global health, they encompass all those experiences that were mentioned before, such as volunteerism, medical missions, etc. This terminology is used to move beyond the colonial and power dynamics embedded within the previous use language. So that's why we're trying to use STAG now. The principles really apply to any length of global work where a group of providers from one area go and work in another. There's 4 key positions taken by the ACF that I think are really relevant. Oh, sorry, 5, I apologize. And that really provide a good framework in thinking about ethics in short-term experiences. And they address a lot of issues that are problematic in STEGs. And so, for example, a suboptimally conducted short-term experience in global health can lead to inappropriate clinical care, can undermine long-term community health outcomes by shifting responsibility of care from the government or local institutions to the STEG or the foreign providers. So position 1 is physicians' primarily ethical obligation in STEGs is to improve health and well-being of the individuals and communities they visit. So primary ethical responsibility is to do no harm, which is that, beneficence and non-malfeasance. So it goes back to our professional ethics. So there's a reason why I was mentioning it before. Remember that doing no harm may also mean not treating. For example, there's a lot of work being done in Africa about out-of-hospital cardiac arrest. Is it appropriate to perform out-of-hospital cardiac arrest when there is no definitive treatment, there is no PCI, or there's no TNKs, there's no other step So is it the right thing to do? So for example, say you're on a short-term experience and you have a supply of antihypertensives and you want to give it to a patient to start because you think they have essential hypertension. Well, what happens when you leave? Like, do they just run out of medicine? Is there a linkage to the system? So sometimes doing nothing is better than doing something. And STAGs are no longer better than nothing. So now we really have to demonstrate a real benefit to the local community with a goal of sustainability, which if someone figures that out, I think you're probably in the Nobel Prize. Also, you want to think about what are the resources the community has when you leave. So it's really trying to integrate yourself in that local community, and that's why you need local champions and work with the ground people on the ground who really should be leading the effort. You want to adhere to ethical standards. So, for example, a lot of times people want to give expired medication and equipment, which is actually usually prohibited by the WHO to use. And so, just because it's something doesn't mean that it's better than nothing. Do not exceed the scope of practice, which we talked about, and adhere to local licensing guidelines. Taking the lead from the local community is paramount. Your actions shouldn't detract from local clinicians and resources. And remember power imbalances that pre-exist that are perpetuated by this work. At the end of the day, we should know who and what is the benefit and is it worth the cost? Because there's always a cost to be had. So the second position is the ethical principle of justice requires partnering with local leaders to ensure that the potential burdens participants can place on local communities abroad are minimized in preparing for limited material resources. So justice requires that physicians seek to equitably distribute the life-enhancing opportunities afforded by healthcare. So we worry about clinical resource limitations and the difference in equipment. Understanding the local context, such as like the WHO essential medicine list, prior to departure will help, but this also means being the least burdensome on the community. Other burdens to the host site, which may result in inequity, is lodging, food, transportation, illness of the visiting physician, shifting focus on local providers to the needs of the physician, such as translation. So, for example, you can have a clinical health officer end up being your translator when really they should be the ones providing the care. Weigh the burden of your visit with the local benefits and needs. So everything comes at a cost. So what is the benefit, and does the benefit outweigh the cost? And then just distribution of limited resources, both interpersonal, clinical, etc. You want to both how much should you and the host community contribute. It becomes a question of who gets treatment. None of these decisions should be made without lead from local clinicians to the right way of dealing with the situation. And for example, if you have a limited number of ventilators, who gets the vent, that should be led locally, and then you're supporting them. Global health equity through moral caring is a very good way of thinking about this. So the position 3 is the ethical principle of respect for persons, including being sensitive to and respectful of cultural differences to SEN. So the ethical principle of respect for persons includes cultural humility, which is respectful of all different cultures, different cultural views of the role of medicine, health, and death in society. Physicians are obligated to provide culturally sensitive care that does not presume the correctness of any one culture's view, either the physician or the patient. Emphasizes solidarity and collective obligations based on social reciprocity. Both cultural competence and, as we talked about, cultural humility are important. And you also want to respect is paramount, and do not forget that some values may transcend borders. So really you want to always go back to the 4 principles that we discussed about our professional ethics. But there becomes a huge ethical dilemma now, probably even more so than when I started this work about 15 years ago. I want to just take a minute to talk about social media. We all want to talk about where we go and what we've been doing, but is it ethical for us to take photos? Is it ethical for us to consent people? And is it really consent, or are we coercing them thinking that they may want to provide us photos so that they can get care? So it's really important to know what is actually being done and if it's appropriate and if it's ethical. So I think social media is really something that we need to look hard at, and really should have a policy with your local counterparts before you go to know what is acceptable and what is not acceptable to take photos of. And remember, just because you're not in the United States or in the Western world doesn't mean that you should, those values of consent and things go away. You also need to be a humble visitor. So it doesn't mean to not speak up. So if you see injustices, then you need to really think about that ethically and have a protocol within the organization you're working with and with local partners on how to deal with ethical dilemmas. So for example, say you have violence between patients or someone wants forced sterilization or forced examination. This, would not happen here in the United States because we take patient autonomy very as one of the kind of cornerstones to our medical care. But globally, you want to look at a trusted mentor and the organization itself, how these are addressed. So don't feel that you should always stand up for your ethical, especially your professional ethics. They should be couched within the culture and society with which you're working, but always know that if you have an ethical dilemma, having that person to go to locally is going to be really important to address those issues. Most times, if not all, there's no right answer to these decisions. So it's important to both look to the local partners and your ethics as a physician to the least amount of harm as possible, but still protect your patients and your morals. So position 4 is pre-departure preparation is in itself an ethical obligation. It should incorporate preparation for logistical and ethical aspects of STEGs, including potential for ethical challenges and moral distress. So moral distress is when physicians are unable to act in ways that are consistent with ethics and their professional values, or they feel complicit in a moral wrong. This is when you should know your organization, who you're working for, who you're going out with into the field, and what their ethos is. So for example, going with a faith-based organization versus going with someone with MSF or governmental or non-governmental, they're all going to have different ethos, and to know that is going to be really important. And then this is actually a great website, Ethical Challenges in Short-Term Global Health Training. It provides 13 different scenarios that you can go through about commonly encountered ethical dilemmas when we work globally. So it's a really good website. And there's also a recent evaluation published earlier this year. Citation is in the references that really look at what this has done and provided for people engaging in short-term global health experiences. And then the last position is physicians should practice with organizations whose STEGs are consistent with ethics and professionalism as exemplified in these positions. So it's important to note the values again of the organization you work with, because that's going to really determine the ethical support you're going to get if you, not if, but when you encounter an ethical dilemma overseas. And so it's important to have clear ethics discussions with the organization you'll be working with and have a plan to deal with these ethical dilemmas as they arise. For-profit global medical volunteer or tourism organizations warrant more scrutiny as a tension exists between profit margins and maximal benefits to the community. I'm going to tell you my bias right now. I don't necessarily or really at all agree with paid global health experiences because I don't think they're sustainable, and it's not, unless it's led from the ground up, it doesn't really have the impact that you think or that that you do. So before we get to the cases that I've kind of dealt with, I just want to talk a little bit about how to approach an ethical dilemma. So an ethical dilemma is a situation necessitating a choice between two or more alternatives. It is a situation that developed because of a conflict of values where there is no one right answer. It's a conflict between moral and ethical obligations within yourself about the situation. And really, when facing an ethical dilemma, you want to ask yourself, what should I do and why should I do it? So really, you want to know the behavior, and I think more importantly, motivation. So it really depends on your own identity. We would hope we could be objective in dealing with an ethical dilemma, but the truth is we are all influenced by our own identity, morals, and ethics. What we understand about morality, which guides our ethics, is dependent on our own upbringing, our culture, and our society. Race, ethnicity, culture, and society all play a role in the development of our ethics. The professional ethics of our field are a guidance, but how we interpret it and act on it is highly dependent on our own identity and moral and ethical compass. So in general, you will face numerous ethical dilemmas, both domestically and internationally. I'm sure you have already in your career. It is important to have a systematic approach to resolving dilemmas. And so it's important to be thoughtful and rational, and have justifications for our beliefs and decisions, and ensure it's more than just an intuitive process, that it's a systematic approach which will help also address inherent biases that exist, ease pressure on ourselves, and promote consistency in resolving dilemmas. So issues to consider when approaching dilemmas. The approach can include defining and identifying the ethical dilemma. So really, what is it? Clarify what is known and not known, and identify all the key stakeholders. Look at the medical indications surrounding the dilemma, the preferences of the family, as well as quality of life, and then of the subjective evaluation of his or her situation. And then also the most important, I think, is the contextual factors. What factors when looking at ethical dilemmas globally when you're working in global health? The most important in global health is the social context, family situation, financial situation, that can lead to, that should be led from the local colleagues. The understanding should be led from local colleagues. For example, if financially they can't, like a patient can't afford the medication, is it ethical for you to pay for it? We'll actually talk about that in that moment. So these are some 3 cases that I personally have dealt with when I've worked overseas and the decisions that I made. I'm not going to say that they were the right decisions or the wrong decisions. They were just the ones that were made in concert with my colleagues overseas. So for the case 1, there's a 36-year-old female arrives with shortness of breath. Past medical history is G2P2, last pregnancy 2 years ago. She denies smoking and asthma, so shortness of breath with increased swelling to lower extremities over 4 days. Those are the vital signs. She's able to speak normally, regular rate and rhythm, but she is tachycardic. This is the EKG that you get. So, you know, supraventricular tachycardia, unclear. So with the essential medicine list with WHO, the only medicine that we had was IV adenosine. So what did I do is that the hemodynamic is stable. So I didn't mechanically control the convert. Sorry, I did not perform cardioversion. The only medication available is IV adenosine, and adenosine was given, and this is the following EKG after that adenosine. So what happened was a patient had undiagnosed WPW, and then I basically increased their heart rate to the 200s. So their heart rate is 225. What do I do next? I did an ultrasound. I, looked kind of like a thrombus. So so in this specific country that I was in, you have to pay for everything before you get that service. So the medications, imaging, everything. And that's true in most countries, especially in low and middle income countries. So even with that, the decision made to cardiovert because the family could pay for Lovenox. And so Lovenox was given. Multiple attempts at cardioversion were unsuccessful. And then the EM's resident that I was working with locally, the local EM resident, says the private hospital has amiodarone, but it's $5, $5 US, the equivalent of $5 US. So residents ask for money to buy amiodarone. Do you give them money? And this is something that seems very simple, but you're actually going to encounter it more than you know. I mean, at least I have, and that might just be my experience. But remember that every action you take, even when you think it's ethical, will have downstream effects. So in my attempt to do no harm, or think that I'm doing less harm, I decided to give the money. So I gave the $5. Heart rate improves to 120, patient improves. Later that week, the patient had the opportunity to get transferred to India for an ablation. Because she can afford amiodarone, she would have to pay for that trip herself. Because they didn't think that she had the need since she had the money to already pay. After several days, I was able to convince the ministry that she couldn't afford the medications, and I had given her the money. So I had to give a mea culpa because it really wasn't appropriate for me to do that. I was reprimanded as it's not standard operating procedure for foreign physicians to do this. And I was told if I did anything like this again, I would be asked to leave the country and not be allowed to enter again. So the patient made it to India for the ablation and returned 2 weeks later. So instead of doing more harm and trying to uphold or doing less harm and trying to uphold beneficence, I did more harm than good, and I didn't respect the autonomy of the patient, and I could have really impeded and literally killed her by not allowing her to go there. So something that I thought was innocuous, I get $5, which is not much for us, especially as an attending salary, and then giving it and not realizing those downstream effects. And so remember that every action, Newton always had that the right that every action has an opposite and sometimes equal or unequal reaction. So it's important to note. So did I make the right decision? I don't know. I was lucky in that case that they didn't ask me to leave the country. And remember that you're always a guest in these countries, so they can ask you to leave whenever they want. There's no protection in that. So the second case I have is a 19-year-old male arrives in the ambulance after a road traffic accident. Vital signs are there. His GCS is 3. He has multiple contusions and lacerations to the head. People's minimally reactive. EFAS is negative. Decision made to intubate, but there's no available ventilators. So what do you do next? So 19-year-old found with the CAT scan was done and an epidural was found. We were bagging him. He was protecting his airway, so we didn't need an immediate vent. Neurosurgery is available for intervention in 2 hours, but there's still no ventilators. What do you do? And then during this time, a 65-year-old comes in with respiratory distress, fatting in the 50s, also needs a ventilator. So a ventilator becomes available, and then the discussion with the team is who gets the ventilator. And there's no right decision in ethics. So together with the local team, we made a decision to bag a family member to bag the 65-year-old male and ventilate the 19-year-old. The 65-year-old died 2 hours later. The 19-year-old walked out of the hospital 5 days later. Did I make the right decision, or did we make the right decision, I should say? And these are decisions we make in mass casualty incidences too, but it's different when we're talking about treatable causes. And so this is a type of comparative justice. Was this the right decision? Should we have just bagged both and not given the ventilator to either? I think the decision on why we made it for the 19-year-old, because we said that that's a very treatable process. This person has a lot longer to contribute to society, it was a very tough case and a very tough course. I took the lead from my local colleagues, and at the end of the day, we made the decision together. I mean, was it ethical? I don't know. And that's always the rub of it all, is that this lecture is great in kind of bearing my soul and letting me process things, but is it ethical? And I still don't know if any of these decisions were. So the third case is a 9-month-old comes in with 90% total surface area burns with 60% full thickness. Patient's moaning in pain. They had a fire in the house. Everybody else was fine. Singed nasal hairs soot throughout the oropharynx. These are the vital signs. And so it was hypoxic, tachycardic, and hypotensive. Oh, maybe not really hypotensive, but mom was at bedside. So this case, like it's even in the best circumstances, the best medical care in the world, it's almost 100% mortality. So what do? There's no burn unit. You are at the tertiary hospital in that country. So do you actively treat the patient or introduce comfort care? So this is a really self-reflection for me, because is comfort care even a discussion, or palliative care a discussion in many countries? I think it's becoming more, and the WHO talks about it more, but culturally, is it appropriate? And it varies widely between cultures. So I kind of went through this when I was thinking about it, of the different professional ethics we have. So beneficence, we want to advance the health of the baby and do the best that we can for that child. Non-malfeasance is the ethical dilemma, really, is do no harm. What does that mean in the setting? Is giving that patient, fluids, antibiotics, and all of those things for them to just die of sepsis a day later or 2 days later, the right call. Autonomy, the mom's at bedside and she actually really understood the situation well. And then what resources do we have to take care of the baby, and what resources are going to be taken away from somebody else? So medical management, as you know, would include fluid resuscitation, wound management, infection control, and emergency department frequently contaminated with resistant bugs. Mom has 4 more children at home, and the cost of daily ICU would bankrupt her. Long-term survival is almost 0, and suffering is high for that infant. Because really I can still hear that infant's moans. It's just, pain is our last feeling to go. And so how do we minimize harm in this situation? After discussion with the mom, we decided to give the baby morphine and arrange transfer home. Baby died waiting for an ambulance 45 minutes after arrival. Did you make the right decision? I don't know. And I don't know if I'll ever know if this was the right decision, if we made the right decision. We talked about the cost to the family, the likelihood of just prolonging suffering, and the high likelihood of death. And so we made this decision, but I think it still haunts me and it's still difficult to come to terms with. So I really just wanted to share these 3 cases just so you get an idea that, of what at least I've experienced and the ethical dilemma that will occur. And to know that there's really no answer and that things will stay with you. And it's good to have these discussions and have colleagues and global health colleagues to have these discussions with. So in conclusion, some ethical principles to guide our short-term experiences in global health. So global health equity through mutual caring and relieving suffering should be our paramount focus. Avoid exploitation of the population you are supporting. Obvious cases are easy to avoid, but what are the issues of social media, for example? So really have that in the forefront of your mind. That is actually a very big ethical dilemma. What to post, what not to post. Should you be taking photos and posting? How to obtain informed consent for photos? As people may think, since you're a foreign doctor, that's okay. But social media adds an additional layer of complexity to ethical dilemmas. You want to establish a cooperative partnership and empower local communities to reduce, if not eliminate, the sense that they are mere recipients of aid. Not providing care outside your scope, also ensuring the community is leading based on local need and constantly asking about those local needs and reassessing. You want to ensure fairness in site selection. So if you have the opportunity to select sites, make sure that you're doing it equitably and that you're not causing more harm. Commit to benefits of social value, ensure benefit to the community, and at least that the benefits outweigh the costs. What are the costs? Try to anticipate unintended consequences. For example, giving up $5 and how that patient may not have gone to India for that ablation. I didn't know that, and so now I do. So really trying to anticipate the unintended consequences of decisions. And constant re-engagement and collaborative reflection with local partners is really what's going to help deal and make appropriate ethical choices, if I can say that. But I mean, really, it's hard to say appropriate ethical choices, but just make ethical choices that you can kind of live with. Not only should short-term work not interfere with local infrastructure, but it should build and improve upon existing infrastructure. You want to have a way to evaluate your outcomes, and you want to ensure to constantly not cause more harm, especially unintended harm. Look at the type of institution you're working with, type of intervention you're providing, and type of relationship with the local community. So these are just some resources that really kind of highlight the ethical dilemmas and how to deal with them in global health. These are references, and thank you. Feel free to email me at any time. I'd love to discuss this more, and thank you for your time.